me a heads up. There it is. Perfect. Thank you. Ladies and gentlemen, welcome to today's discussion. I know we're waiting for the moderators, Marie and Walter. If you're here, just give me a heads up, and then I can hand over the session to you. But for the next hour and a half, we're going to have candid discussion. That's because what is going on is we've been caught pants down, so to speak. We've seen the landscape of the donor financing start dwindling, and we've been found in a place where we're not so sure where to move. But if it wasn't a perfect world, then the domestic financing should be in such a place that it takes care of every financing gap. But the reason why we're having this discussion, ladies and gentlemen, is because we're marking the International Women's Day. We're not biased, but it's because we already know that women, young girls, already are facing so many challenges, and this punch to the healthcare financing is making things worse than it already was. That's why we're having this discussion. What do we do? I know for this year's theme, we're looking at accelerating action, but how do we do that? But we've realized while we were doing and implementing the SHARP project within the Great Lakes region, and this particular project is for 4 years. We're just summarizing our 3rd year, and it's being funded by the European Union. We realize a lot of partners on ground are already doing a lot of things. It could be from tracking what amount has been set aside for sexual reproductive health or women's health, or it could be advocacy efforts just to push governments to implement these international instruments like the ones we're calling for today. The Abuja Declaration, at least we need to get the 15% in the Maputo Protocol. It's high time we ratify and fully adapt this instrument. So for the next hour and a half, I'm going to hand over the discussions. I'm usually the one who talks so much, but this time around, I'm going to take a back seat because the experts are here. And who moderates experts better than journalists themselves? So that's why we have amazing hosts. So the moderator is Walter Nyabaga from Royal Media. I know you've seen this face. He's quite familiar back home. And also Marie Yambo, she's super passionate about health, especially women's health. So the two of them, a political person with a health journalist combined, it's definitely going to be a discussion worth listening into. Trying to work. Yes, see the way I'm very fast, and we've even gotten to the point where it's Q&A. Now, a little bit of housekeeping rules. This is just to make sure we're on the same page. We're all using our electronic gadgets. We advise that if you have any question, please use your electronic hand, and we will accord you the time to actually ask your question. Feel free to make it very short, but direct it to somebody so that you get the feedback that you would require. Always be on mute. Unfortunately, our webinar, we're very flexible. So the minute you get into the call, you're automatically unmuted. We would request you to mute yourself unless it's the time you're, giving in your input. But you've subscribed to, listening into this discussion, and automatically you give us the consent to record you. Do not worry. We will share the recording and any other note that might come out of this discussion with you later on. Do rename your account. As we mentioned earlier on, for this particular project, we want to know who's within the health space implementing any reproductive, family planning, women health issues. And that's why we also want to connect with you while you're here. So rename your account, let us know what your name is or your organization is, and feel free to use the chat function. We need to network. And of course, respect each other. Everybody has their own opinion. We welcome everybody's opinion, and we would like the same respect to be accorded back to everybody who has one-on-one timing. And have fun. This particular discussion has only 3 slides. I've only started with the first one, which is the housekeeping rules. Then I'll go to the next one, which is thanking the partners and all the speakers who are going to contribute later on as we go on with the discussion. Unfortunately, we're only fully running the webinar in English, and we do extend our apologies to other delegates who actually might be speaking another language apart from this. Yes, and then the last slide will be when, we open it up for Q&A. So the reason why I'm going to stop sharing is because this particular webinar is a bit different. I'll double check again and see if our hosts are here. I don't know whether we have the moderators. Anne-Marie, Mariambo, are you here? Walter, if you're here, just let me know. Linda, you can keep an eye out. I do know there's some people in the waiting room. Yes.
I don't know if they can hear me.
There you are. Lovely. I was going to start panicking, but you're here. So I do feel safe.
Yes.
And I've seen Diana,
Right.
Diana Gishengo. Welcome. Welcome. Everybody, thank you very much for joining. I know how crucial it is to have this kind of discussions. It's a time where we're in a dwindling space for funding. But let's be honest, domestic financing should have been strengthened in such a way we don't have to feel the impact of donors minimizing donor funding. So we'll just kick off the discussions. We'll start off with a little bit of keynotes from power women who already are doing amazing things. Walter, are you in the room? Walter Nyambaga? Yes, journalists are always late. I didn't know that. Marie, is it true? This is
No. I wouldn't say it's true. I think we are very, very time focused.
Propaganda all of a sudden.
Yeah.
I'll stop at that before the Kenyans now take me to X. So I'm your host, Lizzie Otai, and of course, my co-host, Linda, will summarize everything later on. We're going to start with the opening remarks, and we have an amazing lady who is actually also implementing this particular project already. Now, when you hear Rwanda NGO Forum, already you know which country that is, but you have notes come across Nuliet and her strength behind implementing a lot of health initiatives that touch directly on either adolescent girls, young women, or women in particular.
No one.
Yes, that will happen, ladies and gentlemen. That's why we have our team who will, yes. It's not a webinar if that doesn't happen. So I'll ask Richard to just make sure that everybody is muted. Thank you. Now,
Lizzie, you're muted yourself.
Yes, the host decided to mute everyone. That is quite unfair. Let me unmute myself. Should be fine. Good. So I was talking about Nuliet and the amazing work that she's doing. She's an advocate for healthy communities with over 14 years of experience, ladies and gentlemen, and currently serves as the executive director of Rwanda NGO. Once she turns on a camera, you'll understand that the bio doesn't do her any justice. She looks like she's 18 years old, but this amazing CV is quite impressive. So she has worked extensively to support organizations and vulnerable communities in engaging decision makers and technical experts at local and national level. So she specializes in strengthening civil society platforms for health, advocacy, planning, implementation, you name it. I'm not going to finish reading her bio because it's intensive, but I'm going to call Nuliet to just give her our open remarks on what they're doing at Rwanda NGO in Rwanda. Nuliet, over to you. I know you're in the call.
Thank you very much, Lizzie. I'm glad to be here, and happy International Women's Day to all the women on this platform and all the men that are really following us from this platform, because we believe that also the men engagement in the response of issues that are affecting women is very important. So happy International Women's Day to everyone.
Just a little bit of hiccup video. You should have video off, sorry, because you're breaking quite a bit. Yes, I think we should be fine now.
I hope you hear me now.
Loud and clear,
yes. Thank you very much. I was saying that happy International Women's Day to all the women on this platform who are following us, and also happy International Women's Day to all men that are on this platform, because we believe that men has a key role to play in responding to the issues that are affecting women and girls, more especially in their health. So briefly, just in my remark, I want to appreciate all the partners that have been implementing with us the SHARP project, especially HAI International and all other partners from the partner member states who are contributing to this. We believe that SHARP project is looking forward to improving the quality of health services for adolescents and young women, not only in Rwanda, but across the region within the countries where we are implementing. So coming back to Rwanda, I want to highlight a little bit more of the achievements that we've made. We believe that there are some achievements recorded, but there are still some issues around quality access of health services for women and girls. Not only the access for health services, but also we need to look at the part of socio-economic part, because for a woman to access services, there's some economic aspect that needs to be looked into. We need to look at, for adolescents, if we're talking about access to quality health services, we need to look at, are those services available? Are they accessible? Are they friendly? We need to look at, as we look forward to celebrate the International Women's Day, we need to keep our mind that saving the lives of women and girls, we need to make sure that all the issues that are hindering the access of quality services need to be advocated for. That means the conducive environment that is needed for those people to access. We need to make sure that we have empowered communities who are aware about the rights of their services. Once they're accessing services and the service is not friendly, they are able to claim for a friendly services because they are empowered. So part of the journey that we have been together with SHAP and other partners, a lot of work has been done. One, we have invested into conducting different research and surveys for more of generating evidences that could inform our advocacy in terms of improving for services of adolescents and young women. Like a survey of interacting with community healthcare providers to understand their experiences and challenges that more especially to understand the challenges and experiences adolescents and young women are facing in terms of accessing the quality healthcare services. And then also we generated evidences around the availability, stockouts, and of commodities, the accessibility, because if we want to improve the health of girls and women, we need to look at those components. And then we had, in our advocacy efforts, we need to be backdated by evidences and showing this is not working on well, here are evidences, and this is what we recommend to make sure services are improved. And then again, I talked about capacity building. In the InShell project, we had to make sure that CSOs are trained. We believe that CSOs supports the government to implement, to make sure that services are available at the health facilities and at the community level. But then we needed to engage CSOs and empower them around the ASRHR holistic package of services. They understand, then they are able to work with us in the journey. And then again, we train the faith leaders. We believe that faith leaders, most of the times, they don't believe in adolescent girls' services related to health. When you talk about contraceptives, they tell you, we don't believe in that. We should, girls and women should give birth until they get tired, you know. And if we are here, it's my body, it's my right, I should be able to give birth since I believe that this is the time for me, I'm ready for giving birth to children. And then also the time I decide to give birth. So I think when you're talking about improving the quality of services or improving the health of women and girls, we need to make sure in this journey we move together with others. So we trained faith leaders because we believe they have a key role to play in this, whether in education, whether in advocacy, because we believe when they're in church, the message they provide to communities, that's what the communities take. So having them as allies in our advocacy, it makes a lot of sense. And then also in terms of conducive, advocating for conducive environment and policy legal environment, this brings in the policies and guidelines and different laws that we have in place. If they are really conducive on this particular part, when you talk about the family planning strategic plan, the sexual reproductive health strategic plan, what does it say? What are the gaps? What do we need to advocate? So we continue to engage in different platforms, national technical working groups, building allies, so that during the planning, reviews of different guidelines, we are there to make sure the voices of the women and girls are heard vis-a-vis improving the services that are linked to improving their lives. And then again, something I could highlight here that is really very important for everyone to know is about the health service law that is being revised in Rwanda. We are engaging fully to make sure that once the law is adopted, we have to make sure that the ASRHR services for adolescents, they are allowed to access services at the age of 15 years without parental consent. Because if an adolescent girl wants to have sex, she will not go to request for permission from the parents. But when she gets pregnant at the early age, there are a lot of problems she will face. She will drop out from school. She will start to raise a child, taking care of the child at an early age. Financial aspects, she doesn't have finances to take care of the child. And then all those risks can lead the adolescent to even tend to be a sex worker because she wants generate resources to cater for the child. And if she's not empowered, the HIV related diseases can start, that young girl can be exposed to that. And then conflicts in the families between the parents. It's your child, you're the one who made this, who did this, the back and forth. So we need to make sure this adolescent girl or this young woman is protected, is having the right to access the services related to sexual, reproductive, and health, because we believe the lives of the adolescents and women matter. So we are engaging in this. We wrote a position paper to the parliament. We've been into the commission 2 weeks ago, engaging and discussing, providing our inputs and ideas that could inform the decision makers, parliamentarians, to address all the issues that are hindering adolescents and women towards accessing the ASRHR services. Lastly is about awareness and education, where we use the digital and media platforms in terms of raising awareness about the lives of women and girls related to health. And then also we use different journalists, different platforms, community settings like campaigns, meetings at district level, and then also through the technical working groups that we established at the community level, and also through different roundtable meetings at the national level. To cut the story short, because I know I have limited time, I want to call for action during this International Women's Day that there is a need of a multi-sectoral collaboration of all institutions to make sure that they all contribute towards the lives of women and girls, because our lives matter. Having services available, accessible, affordable, this is the only way to go with saving the lives of women and adolescent girls. Thank you very much.
Thank you very much. I should have just let that be the closing remarks. After that, we're supposed to just call it a day and go home. But thank you very much, Nuliat, for that. Ladies and gentlemen, as I mentioned, you're used to hearing my voice. This time round, we have the media running the show, and I only took over because I could not see him. But Walter, just to double check, you're here, right? Walter Nyambaga, I can tell you're here.
Yes,
There you
Liz,
are.
I can be clear and hear you very perfectly well. I must
Great.
admit, my internet here in Kenya has been up and down. I don't know if there are so many people using it, logging into this session, but
Must
perfectly.
be. Okay, I'll hand it over to you so that you can call in the next keynote before Marie takes over. So over to you, Walter. I already did a beautiful, beautiful introduction about you, but you're not here. But I hope I'll send you the recording. But it was at 100% for sure. So over to you, Walter. After that amazing reintroduction, then he goes quiet. Ladies and gentlemen, this is expected. As I mentioned, it could be because a lot of people are also joining in, but we'll proceed. That was Nuliat from Rwanda NGO, and as from Hadi's keynote, we need to accelerate action, but we need to have allies and we need to understand what the problem is, but we also have to capacitate as we go. Now, ladies and gentlemen, our next keynote is coming from Diana Gishengo, an empathetic leader and a seasoned human rights advocate. Now, we need to behave once you hear human rights in the room. So Diana drives meaningful change to transform lives across Africa with over a decade of experience in policy development, advocacy, campaign strategy on human, economic and social rights. She excels in diplomacy, contextual analysis, and navigating complex political landscapes. I told you, the women we have today, their CVs honestly doesn't do them any justice. I'll just stop at that, but call Diana. Diana, if you're on the call, because I remember I did see you log in, just let's double check that you're actually here, Diana. There you are. It was good. I saw you for a split second. Perfect. There you are. Diana, over to you. I know you have 5 to 7 minutes, and I'm trying to have you kind of compress everything in that amount, which is next to impossible. But let us have your keynote. Thank you for joining.
Okay, I didn't know it was a keynote. I knew I was coming to contribute.
Don't worry, we have you all through. So give us your parting shots, then we bring you into the session.
Okay. Thank you very much, and thank you for that particular introduction. Very gosh, I don't know where you got it from. Anyway, for these purposes of this discussion, I work at the Institute for Social Accountability. And what we do is we drive accountability by looking at how government budgets look like year in, year out. And I know we are having this discussion in the background of what the withdrawal or the cessation of USAID by stroke of a pen. So like spit out rule of law, due process, and you wake up, what you don't like, you remove, and it has all these implication on human lives, dignity, and most so the lives of women and girls in areas that matter very much, particularly sexual and reproductive health, HIV, and there are even other minorities. If you think about gender and sexual minorities that have been placed in a different category, it's extremely concerning. Having said that, I come from Kenya, and partly if I meet a government official, I'll tell them, look, we told you that health should be financed by our taxes. Education should be financed by our taxes. Things that help us to produce food and things like that should be financed by our taxes directly, because we already know the type of taxes we collect, how they grow or go down. They are very well defined. So if we had only prioritized and gotten to particularly the provisions that were there under the Abuja Declaration of 15%. And in Africa, one of the nations that has done well is Botswana. They are able to resource their health to that particular level. They may have a very high HIV prevalence rate, but I'm sure they're not having the same hue and cry as, say, Kenya, Malawi, Uganda, and other countries are having. But currently, I've told you, Lizzie, I'm working on budget. But during the COVID-19 period, I was also working on issues of health, and it was extremely worrying. For Kenya, the highest percentage we've ever gotten is 8.9. And that was during COVID, when our leaders couldn't fly out of the country to get the required healthcare that they would hope for. So during that period, they got worried and realized we needed to resource all hospitals with beds, because then even their relatives, they will die as they look and they can't ignore as much. So there was a certain awakening that happened during the COVID-19, the lockdowns and the reduced travel. But the highest we ever got to was 8.9%. During that period, when we were campaigning for a COVID-19 vaccine, we realized that for Kenya to use its budget, pay, purchase vaccine, it would only have been 1%. of the national budget. Then 1%, everybody's vaccinated. Then COVID was one of. HPV does not even require the whole population to be vaccinated. But what happened? Immediately after we moved from 8.9, in our last budget, Kenya was at 4% of the national budget was allocated to health. And we got this moment of genius where we decided the people with payslip can pay more for the social health insurance, and we will categorize it and only use it for chronic ailments and emergency. And then we will decide that for this type of financing, our public hospitals will compete equally with private hospitals. What does that look like? It means there is the amount allocated from taxpayers to strengthen our public health system and infrastructure reduces significantly. You then rely on a small percentage of the Kenyan population, 20% who have payslip, to resource the entire health system, and only for emergency and chronic ailment. Yet everyday maternal health care, reproductive health care is considered to be very, is it level 2 and level 3 type of health. So people, if you're, and our current covers, what it provides for, you can't even be covered for a full implant under this social health insurance. Initially, they had done away with free maternity care that existed before. So you're coughing more, and when the few people with a payslip cough more money, it means the people who rely on them have reduced access to that particular income. Because for me, the village that relies on me, the minute you take close to $200 from my payslip to go to the health insurance, that's the money that was partly part of the black tax that you pay. That has not taken away the need. It has increased it and deepened it, because I've covered reproductive health, but if you think about what has happened to most of the chronic ailments that were covered, say, at 100%, they are now covered at 10 to 30%, from dialysis to diabetes to cancer care. And in Kenya, the leading forms of cancer are very much linked to women and their reproductive health. It is cervical cancer, it is breast cancer. Somewhere in there you have prostate and you have stomach cancer. But what are we doing when we do not have domestic? What would it look like if we had actual domestic financing from taxes? It would mean that we are able to invest so well in, immediately we got devolution between 2014 and 2015. Some of in Kenya, we have a devolved system of government. So we have county governments and we have the national government. Counties run the bulk of our healthcare system. They're responsible for level 1, so prevention, preventive health, public health, and so on, mosquito nets, things like that, basic sanitation, all the way to level 5. Level 5 means you can get all your basic operations unless they need very, very highly specialized processes. So they run all that up to level 5, and the national government is supposed to have the more complicated referral health and policy. During that period, counties identified what they were very good at. They invested in research. So for instance, a county like Nyeri invested in research around diabetes. They got expertise. They even ventured into alternative medicine, let me not call it traditional. It is what it would mean to create the best cure, the best generation of medicines to be partaken by people who are suffering diabetes under the current environmental and social conditions. So that was getting us to where most of the developed countries are in terms of producing very, very current medication. So across across the country, across the country, we had various areas. We were even thinking that if we consistently invest our taxes in health, we will soon get to the level where part of how we earn our revenue is health tourism. But somehow that because our government and I don't know, our policymakers do not love progress, all that was cut short, and then all of a sudden, procurement for health financing was centralized, so that then people, all counties, 47 of them, would procure for medicine together. Apparently, it was because of economies of scale. But what ended up happening was we procured equipment where there were facilities that could not house them. So you have something to do scans and so on, but the county that is allocated has no health facility that can take a 10-foot scanner. Then medication was also procured that way. So we lost the innovation that we were working on. Unfortunately, that particular process of procurement in our records is now part of a huge scandal that cost taxpayers 4 billion Kenya shillings, that is several millions USD. It is what was already raising questions around PEPFAR and that level of corruption. You know, because it feels like health is such a tokenistic humanitarian charity affair, we do not question enough how that money is utilized. But if it was to get to the level that you know it is your tax that is here, we would be willing to pay more, but we would demand higher accountability. And what is even more curious, where that money comes from, say, the World Bank, and for some instances, some of the EU funded and the USAID funded. The government, our government, and I'm sure neighboring countries as well, take every step to make sure they get a zero-fault audit. But immediately thereafter, the money that is allocated using taxpayers cannot even come anywhere close to a qualified audit. So until we start investing in socioeconomic rights, and particularly the right to health, and make it a priority, the same way we prioritize funding for election, funding for security, we then come and prioritize funding for food security, for nutrition, for health, using our taxpayers, we will remain a very, very sick and poor nation. And currently, it does not help that most of the money that would have gone to help the domestic financing is going to repayment of debt. Debt that was purely utilized, taken into infrastructure development, and is mostly used to pay for interest by capital owners. As we celebrate the International Women's Day, most of the of the owners of capital who earn interest from bonds, bills, Eurobonds, and so on are not women. So you're going to a process that just continues to enrich the people who have money and take away from the people who are poor, and also leave them miserable in terms of health deliverables. Thank you.
Okay, great. Then I'd love you to go on and on and on, because I think this is what we were supposed to get us an interview when the CS was being interviewed. I mean, if you're running for office, do let me know. You definitely have my vote on that. But we do know we need more people like Diana on the human rights side. So we appreciate the position you're hosting. So thank you very much. I'm going to hand it over to Marie. I mean, we started off from Rwanda. We're telling you what we're doing as the SHARP project in terms of advocacy, women's health, adolescent girls' health. Then we've taken it to a more technical. Numbers don't lie. We've heard about the 1% a budget that can actually make sure the whole country can be vaccinated. We've taken you to investment cases that need to work. And that was Diana bringing you the numbers that, you know, really matter. Marie, are you in the house so that I can stop talking, or else I'll end up making this show all about me?
Yes, quite attentive.
Over to you, Marie. Thank you.
So thank you so much, Lizzie, for this invitation to moderate this session. I must say, Dana, that was quite an elaborate, explanation. And as a journalist, as you're speaking, what I'm thinking about is the story ideas. And do not mind if I get your contacts from Lizzie and get to invite you to just talk about these issues. For those who don't know me, my name is Marie Yambo. I work with the Kenya Broadcasting Corporation. Generally, I'm a journalist, reporting about everything, but I've also specialized, in health reporting. And so when I was invited to moderate this webinar, I mean, what a better place to be in and just learn from all of you. So I'm here not as an expert, because as journalists, we are not experts. We rely on the experts to give us information. So in this particular session, I think I have about 4 speakers. Gerald Kibala, Ministry of Health, Tanzania. There's also Stephen Kibendio, is Youth for Sustainable World, Kenya. Civil society leader advocating for women's health, Immaculate Owo Mugisha. I hope I said that right. And then a representative from an international development partner, Ange Morey from the Netherlands, and the young women's health advocate, that is Blessings Wire. So I think for me, Liz, if I'm not wrong, is just for the speakers to take to take stage and just give us their presentations, and then probably we'll have a chance to ask questions and all that. And for me, definitely, it's a good learning experience. So without any order, I don't know whether we have Gerald with us.
Yes, here may I?
Okay. So I would want to give you the chance to introduce yourself and yes, and give us your presentation.
Okay, thank you. Habari za mchana. Good afternoon. My name is Gerard Kiwere, working with the Ministry of Health, Tanzania, the National Coordinator for Adolescent Health and Gender. First of all, I really appreciate being part of this webinar. Actually, as a Tanzanian, I'm proud seeing some initiative on the ground, particularly focusing on the issue of adolescent health, the sexual reproductive health and rights. This is a kind of meaningful engagement, the male involvement. We are talking about the International Women's Day, and now men are in stage. So happy International Women's Day. As others said, yes, I will be touching both the efforts and initiatives around the sexual reproductive health here in Tanzania. Tanzania collaborates with Africa region bodies and the member states in ensuring effective implementation of revised the Maputo Plan of Action on sexual and reproductive health, which in line with the Africa Agenda 2063 that calls for inclusive growth and sustainable development for prosperity Africa. We have a number of commitment that aligns actually with the international treaty and commitments. The government of United Republic of Tanzania prioritize the health of women, children, and adolescents as it remains committed to the UN Sustainable Development Goals of reducing the goals burden of maternal mortality to less than 70 per 100,000 live births by 2030. Tanzania Development Vision 2020 to 2025 calls for improvement of the quality reproductive health services and 3/4 reduction of maternal infant mortality. In the same vein, The commitment for reduction of maternal mortality is articulated by Tanzanian 5 years development plans, 2021-2025, the Health Sector Strategic Plan 5 of 2021-2026, and the National Plan for Reproductive, Maternal, Newborn, Child, and Adolescent Health and Nutrition, that's 1.3, 2021-2026. Those are some strategical national documents that aligns actually with the UN Sustainable Development Goals, that aligns actually with the some of the Abuja declarations, the Maputo Plan of Actions, so as we can attain our goal as a country, but as a region. Several high impact interventions have been implemented in Tanzania at varying scales to responding to these targets across the 6 WHO Health system strengthening blocks. These efforts has yielded promising results as a burden of maternal mortality has declined substantially. The government has been improving the health sector financing persistently. Now the Abuja Declaration. The government has been improving the health sector financially, financing persistently. The budget for the health commodities increased from Tanzania shillings 31 billion in 2015 to 2016 to Tanzania shillings 269 billions in our report of 2018-2019. Furthermore, the budget for the health sector as a whole increased from the Tanzania shillings 577 billion in 2007 to 2008 to 2.8 trillion in 2020 to 2021. The budget increases led to constantly availability of supplies at more than 90%. These improvements have contributed to rising of the health facility delivery from 63 to 85%, and antenatal care attendance within 12 weeks of pregnancy has increased from 25% to 90% within past 10 years. Tanzania has managed to reduce the maternal and the newborn mortality because of the investment in improving the quality maternal care, especially during the intrapartum and the perinatal period. The high level support has been a key to this gain. We are working hard to sustain the current gains and accelerate efforts toward the SDGs. To address the challenge related to adolescent reproductive health and well-being, the government called for the development of the National Accelerated Action Investment Agenda for Adolescent Health and Well-being, the 21-22 to 21-24-25, the NAIA. The agenda was developed in consultation with multiple stakeholders, including adolescents. It focuses on opportunities in adolescent health and well-being by prioritizing areas of high impact potential and those with existing momentum in addressing challenges. Also, the agenda built on the National Adolescent Health and the Development Strategy of 2011-2015, focusing on catalytic and accelerated action and investment for adolescent health and the well-being. As it results of implementing the strategy, the rate of teenage pregnancy has been reduced from 27% in year 2015-2016 to 22% in year 2022 report. So if I have to rate in terms of percent, if I would to rate in terms of percent on the Abuja Declaration, perhaps the Tanzania, it ranges actually from the 8 to 11% on the health sector budgeting. We are almost there to 15% of the Abuja Declaration as a country committed. So to make things go, we think we have to work together to attain the agreed objective and to make sure what we have been committed in Abuja Declaration and Maputo Plan of Action should be achieved, and we have to spearhead it so as we can get what we want from those ratified declaration. Thank you.
Well, thank you so much, Gerald, for that presentation and just giving us a rundown of what the Tanzanian government is doing in as far as improving healthcare services and even the budget. So I guess, Lizzie, what we'll do is we'll first have the presentations and then people can ask their questions after all the
Yeah,
speakers have.
that would be awesome. Yes, I can just hear a little bit of echo from, I don't know whether it's
Okay.
your end, but we should be fine. Yeah, carry on.
Okay.
Thanks.
So our next speaker is Stephen Kibindio. He's a health financing analyst with Young for a Sustainable World, that was formerly DSW Kenya, and specializes in budget analysis and public expenditure, tracking to strengthen domestic resource allocation for adolescent and young people's sexual and reproductive health programs. And just as we've already had, we are actually gearing to the International Women's Day, and coming, in the background of, health funding cuts and all that. So I think, Stephen, you'll be able to give us quite an elaborate presentation here. I'm more interested in finding out, if possible, how in our setting in Kenya, or even in Africa, how we can collaborate, especially in the face of budget cuts, to, what are the innovative ways that our governments can actually start looking at, to fund our health sector from within the region. Stephen, I don't know if you're here.
Yes, I'm here. Thank you so much, Marie. Yeah. Good afternoon to everyone listening to us. I'm Stephen Kibindio, and I work for Youth for a Sustainable World, who were formerly known as DSW Kenya. And YSW has been has invested heavily in terms of analyzing budgets for over 10 years now. And we have been very critical looking at the adolescent and young people's sexual reproductive health. As an organization, we believe that most of our adolescent and young people, they hold the largest population, and we shall be even taking some of the spaces in decision making just because of the movement that we are creating. Now back to the subject of adolescent and sexual reproductive health. When you look at and this is now in response to your question, Marie, where do we start when it comes to health financing? In most of the times, we have seen that budgets are informed by the ceilings that are set by the previous financial years, and at times it does not look at the situation that our women and girls are going through at the community level. As YSW, we are so much looking at the allocation being done at the facility level, from the community level to the facility up to the sub-county and the county and national level. So we are so consistent when it comes to that chain, so that we ensure that issues that are raised by our women and girls are featuring within our budget allocation. And I want to give you a scenario of how does the community, or how does our women and girls feel change when it comes to health sector. They don't necessarily pay attention to how much we allocate, but they pay attention to the services that they receive, the commodities that they will get. We are not talking about universal health coverage. We are talking about investing in primary health care. So how does that service now trickle down to their household level? And that is where now we start when we're doing advocacy for increased health financing. And I'll give you what we have done. In the past 2 or 3 financial years, we have been analyzing the county budget to try and see how much we are allocating when it comes to adolescent and sexual reproductive health. I can say that over the years, we have seen there was first of all an arrangement that pre-devolution, when we had the local government system in Kenya, that was before we started implementing the Constitution of 2010. We saw that there was a pre-devolution commitment of allocating resources to 35%. When the county government system started in 2013, that is when now we saw that we were about nearing that commitment in Kenya as now Kenya commitment, where we saw some counties doing at least 30%, 29%. Though the amount was smaller, but currently the allocation towards health sector has increased. However, when you look at the percentage of the total resources being allocated to our counties vis-a-vis what was previously, it is currently reducing. However, the actual amount is increasing. So this means that the kitty for the county government is growing. The allocation that is coming from the national treasury and also the on-source revenue that the counties are able to generate is also increasing. However, the percentage that we need to allocate to health is reducing, and that is where we can start from at this point. I don't really feel that the health workforce is enough at the moment. Commodities at the facilities are not enough. Infrastructure within the health facility are not conducive even to attract more customers, more clients from the community. And when you look at new reforms, new laws that have come in the last 2 years within the health sector, it's so I would say it's good in some way because it brings resources directly to the facility through the primary healthcare fund. However, are our facilities able to generate more resources that will be apportioned from the national government through the PHC fund? So those are some of the dynamics that really disadvantages some of our level 2 facilities within the counties, and even the process of even claiming, and this is something that I totally agree with Diana when she talked about the health financing system in Kenya and how the 3 funds is going to revolutionize the health sector, but it is not doing it at the moment, though we really need a lot of advocacy to realize that. And for us to improve our health financing to our level 2, most of the counties, you'll find that 80% of the facilities are level 2 facilities. And that is where services are closer to our women and girls within the community. And majority of the people taking up these services within the facility, especially level 2 and 3, are women and girls. And this is where now we see investment is not trickling down. Investment is delaying, and this is a worrying trend for counties that have got issues to do with that have got challenges when it comes to offering reproductive health care. And the indicators of reproductive health is not that good. It's not that nice that we can be able to pat our backs and relax. We really need to do a lot of advocacy to get more resources. Looking at what YSW does, we try to look at health financing in 3 ways. One is that we look at from the policy level. An enabling environment talks about a good policy. For instance, when you have got policy that says an adolescent girl needs consent from their parent to take up a family planning service, that is already a disadvantage to most of the girls, because sex in itself, it's a very uncomfortable conversation within our communities, within our households. So how do you even seek consent from your parent that you need to accompany me to a facility to take these services? So most of the people are really not going for these services because of that cultural setup. So policy should be favorable so that we can even ensure that we have got people taking up these services. And then the other aspect is on the issue of now the supply in the sense of, do we have competent healthcare worker to offer these services? Some of the healthcare workers are even running away from providing IUCD, the COPATI, as a method of family planning due to the procedure that it involves. They feel that probably they're not that competent enough to offer these services, and this is a long-term method that could even help our women to plan their pregnancies and also to to be able to have quality families. And then the other aspect that we look at is now on the budget, and this is now the gist of our discussion today. The budget it's a very critical component, and we have heard everywhere that budgeting process in Kenya is a political process. But I always tend to argue out that why should it be a political process, yet there are social issues that don't really care about politics. When someone is sick, when someone wants to get services, we should not be really at a point of politicizing it, but actually making it a requirement. And this is now my call to action to actually the actors within the government. Let us have a clear cut within our policies, within our strategies, within our constitution, for the amount of allocation that should specifically go towards health. And this is something that should be able to be tracked on a regular basis so that we ensure that we attain that. In instances where we have seen obviously the economy grows, it doesn't matter how it grows, whether it grows slowly, but whenever it grows, then also the health allocation needs to grow. The population of Kenya is also really growing. When you look at the total fertility rate of Kenya, each family currently are doing about 3 children or 4, 3 to 4 about there. So when you look at that population growth in Kenya, and the health financing is not growing in tandem with the growth in the population, so that already creates that press on the available resources that will be able to offer to our young people and our young women. Now, looking now at the national landscape, and I really loved how Diana painted it. It was so clear that we are missing out something. We have tried with the SHA, we have tried with the FIF. Some counties are even not implementing as per the national guidelines, whereby when we talk about FIF is the facility improvement financing. Other counties have even coined some word calling it a fund, so that we can create a level of fund managers. But that is not necessary. That is not aspiration of our constitution, because we really want, when the facility that is generating money, let it be able to spend the same money within the particular facility to improve the infrastructure, to ensure that there is sufficient operational resources, so that when a woman is going to a facility, she won't be asked to go and fetch water to go and use during the maternity service. That is then FIF was there to cure such kind of a situation. So if we again create some level of fund managers, then that denies that particular facility opportunity to plan for its resources and even adequately have the necessary commodities and tools that they need to offer services. So whenever we have got a very progressive law, then we see implementation.
Maybe Stephen,
of
just
it.
sorry, we just in terms of time, I know you have a lot to say, and it's all I know also the Q&A will need you to kind of give all this other input in. Maybe you can just summarize. Sorry about that. Yeah.
Okay. So basically, we have got good policies, but now implementation of it is quite a challenge. And for us who are mainly keen on budget analysis, we could see some positive things in terms of trends. However, the allocation, despite the fact that it's growing, but we still have got deficit that have accumulated over the years, and also with the pressure that is on the population that is growing, we really need to do more than what we are currently doing. Over to you.
Thank you. That's for sure. I don't know whether Marie is still there. Maybe for the next speakers, let's just keep time, because we also need to open it up and have discussions with the other delegates. Thank you.
That's all right. Thank you so much, Steve, for that presentation on health financing and all that. I recently learned about the FIF, by the way. And for me, when it comes to health financing, what actually matters, apart from the fact that you've said the common person doesn't really care about how much it is, they care about the services. When I come to the facility, am I able to receive the services I need? But then there's the issue of accountability. That is also another very big issue, another, something that probably we could talk about at a later date. But right about now, I want to introduce our next speaker. That is Immaculate Omugisha Bazari. I hope I said it right. She is a Ugandan social justice lawyer specializing in health and gender justice, and serves as the executive director of the Center for Women Justice Uganda. She holds leadership roles on multiple governing boards, including the Uganda country coordinating mechanisms for the Global Fund, the International Community of Women Living with HIV, and the HIV Justice Network, among so many other credentials. Thank you so much, Immaculate, for being with us. The floor is all yours.
Yes, thank you so much, Moderator Mary, for that kind introduction. I'm looking at how the other speakers are shaping this conversation. Clearly, most of the issues are being well highlighted, but I'll bring the gender lens. What does this financing mean for women and girls within our different countries, but importantly for us as East African community? And I will start with how the recent crisis, I must say, for lack of a better word, it has put us into a naked situation in terms of how our health financing and prioritization is standing. We've seen the panic that has come immediately. The freeze was brought to our attention. And the panic indicates that as a country, we've not been ready, and we've not been addressing the key fundamental rights on right to health, but importantly on how do we ensure that we continue access to services, knowing that the majority of people who frequent the health sectors are women. And I'll start with giving key highlights. When this funding crisis happened, the international community of women living with HIV quickly did a survey, and the survey was looking at how is the crisis affecting women and girls in our diversity across the different countries, because we are a membership country of Rwanda, Burundi, Tanzania, and Kenya, including Uganda. And the key things that most of the respondents were able to raise, that how are women affected. One, we saw that there is disruptions in maternal and child health care services, especially lack of essential medications, food supplements for the infants and those who are newly diagnosed, diagnosis. And we also saw that key things like test kits were not available, including the PrEP services for those who have been exposed. And the second key thing that most of the women and girls that raised were fears around stigma and discrimination in these facilities across the different countries. And then the emphasis was also on shortage of medication. We had voices of women saying that, you know, I went to a facility when I've been getting 6 months medication, I've been given, let's say, 3 or 1 month. And we know the implication and the financial cost that has on a woman. For a woman to be moving after every month to go to a facility for a refill, that has a deep, deep cost. So that brings a whole question of how have we been prioritizing our health, and how have women been supported to ensure that access to essential services, including SRHR that colleagues have spoken about, and family planning methods. We know that family planning methods are highly, especially for us in Uganda, most of the family planning methods were funded by the US government. The cutting meant that we may not be able to access certain essentials around family planning, including condom, and that has a lot of implication on young women and young people generally. And then secondly, that issue around the commitment. I think we talked about the commitment. It also shows that how are we committed to the Abuja Declaration of 15%? How much is government putting in? And when all this was unveiled and we see the panic, as a community here in Uganda, we use the experience of Uganda, we gathered ourselves and we started to demand that we need to see increased domestic financing for women. We need to see increasing domestic financing for all people living with HIV. And we engaged members of parliament, we engaged our Uganda AIDS Commission, and we are seeing baby steps progress. We are seeing political commitments of increasing funding, but a question that remains is, out of the money that we are pushing for a supplementary budget, and I believe this could be the same for the different countries, is how much is going to be there for domestic, for communities. So the question, as we call on our actors to invest in domestic financing, what we need to center is what budget is there for communities, what budget is there that is going to support women and girls, so that we are able to know that actually we have our peers being supported. The village health teams, who are mostly women, who are mostly young people, how much is there that is going to support the work, the incredible work they do at the community? So that remains a question that is not answered as of now, because we are just advocating for domestic financing. But for us as advocates, let's center communities in this advocacy and be selfish to center in terms of how much is for women, how much is for girls. And it also, this takes me to the recent, for those who are in Uganda that are on this call, recently there was a whole huge headlines in the papers where they are saying that government has actually broken the promise and let down the young women when it comes to menstrual hygiene, because those are things that are still taxed. Menstrual hygiene is taxed, and we are seeing a number of girls who are not able to go to school because they cannot afford pads, because they cannot afford sanitary pads. And those who, I was on a call where someone said that if they did a program and they took pads, but when they reached in the community, the girls asked them and challenged them, "You're giving me these pads, but I do not have the tools, the panties, where I'm going to stick this sanitary pad." So understanding the needs and desires of women and girls when we are advocating should be at the center of our advocacy. We also know the insurance scheme is still a big challenge. For maybe some countries, there could be progress, but for Uganda, it is just a discussion that has not yet gotten a political will. But if we get this insurance, how is it going to enable women and girls? And women and girls, we are looking at those that we call to be at the grassroots. I don't like to use the word grassroots, but those that really I most need. How are we enabling them to access these services? So I think for now, I'm speaking in terms of posing questions, but the questions is to enable us reflect deeply on what do we need for women. If we say inclusivity, if we say equity, what budget should be available for women, and how do we track these budgets? Beyond just knowing that this percentage has been allocated to health, we need to know, out of this budget allocated to health, how much is for women, how much is going to support the initiatives for women and girls, so that we hold our governments accountable if we get the needs and the challenges of women not being able to access some of these services. Yeah, I'll pause here for now.
Thank you so much, Immaculate, for that presentation. The community-centered budgeting is what you're talking about. And so I'll give this floor now to our next speaker. And I'm actually being reminded 5 minutes for each speaker so that we can have time to take as many questions as we can. And Ange, I think I saw her, she's here. She brings over 15 years of experience in project management, capacity strengthening, communication, and stakeholder coordination across sectors such as children's rights, local governance, and urban safety. Thank you so much, Ange, for being with us.
Thank you, and hello, everybody. Happy International Women's Day. I'm very excited to be part of this webinar. Also very pleased to hear all the great presentations. Although I must say, every time I hear one, I have less and less things to say because the speakers are amazing and already making great points. So I think, fortunately, I'll be a bit shorter. Just a quick introduction. So my name is Ange. I'm French, based in the Netherlands. I work for the organization Health Action International, which is an organization dedicated to advancing policies that enable all people to achieve their right to health. The way we do that is working with our team and a global network of local organizations. And we carry out research to inform evidence-based advocacy for equitable access to affordable medicines and healthcare. But on the subject of today, sexual reproductive health, well, we implement with 6 partners the SHARP project, Solutions for Supporting Healthy Adolescents and Rights Protection. It's a 4-year EU-funded program implemented in 6 countries in the Great Lakes region. We are working in Tanzania, Zambia, DRC, Burundi, Rwanda, and Kenya. I see many of our partners are here today, so hello, colleagues. I think Nuliet has given a great introduction to the SHARP project. Just to give maybe quickly a little background on why this project. Well, of course, in the Great Lakes region, there's a very high level of young population. And these young people also need access to sexual reproductive health services and commodities. What we also see is that in many of these countries and at the regional level, there is a legal framework or policies that exist in terms of access to sexual reproductive health commodities and services, but a lot of time these policies are not really implemented or followed in the healthcare centers and in the countries. We know that also the young people will face a lot of religious and cultural barriers when they try to access the services and commodities. And this is why we really involve a lot religious and faith leaders in our discussion and create space for them in policy-making spaces to make sure they have a word to say in the policies that are developed, in the initiatives that are developed for the young, and they can also disseminate the information in their constituencies. On the subject of today, on domestic funding, of course, as an organization based in Europe, we've been following the different budget cuts that have been happening. We can talk about the USAID cuts, but also the government of the Netherlands, the government of the United Kingdom, and other governments, unfortunately, who were the biggest donors supporting sexual reproductive health, have decided to cut their budgets. This has a terrible impact, of course. Many organizations that have been local organizations that have been providing family planning services or even sexual reproductive health services in general, they not only face financial insecurity, but it's going to undo so much progress that have been achieved in the past years. For example, a number that we have found yesterday in our team is that the US cutting fund cuts has already denied over 5 million women and girls access to contraceptive care. This number is rising every day, so it's devastating. But apart from funding cuts, what we fear is that it's going to fuel gender inequality and it's going to weaken health systems. Through our SHARP project, we have done a lot of research on the availability, accessibility, affordability of sexual reproductive health commodities, but also discussing with healthcare workers on their attitude towards providing these services. And we have seen firsthand that the risks are enormous of early pregnancies, high maternal mortality, unsafe abortion, and rising rates of STIs. I think to go back to what has been said by the different speakers today, I think that domestic funding is obviously crucial. There's no more choice. We cannot depend anymore on the donors as organizations and also as governments. But I think if I can add a little bit to that, I think that budget allocation alone is just the first step. There are different things that are needed on top of domestic funding. First of all, we need to strengthen the legal framework. So as I said earlier, there are, and as mentioned by Stephen, there are existing policies at the regional and national levels around sexual and reproductive health. What we have observed is that a lot of time these policies are not operationalized. They are not known by the healthcare workers, for example. They are not disseminated properly to the communities, to the healthcare workers, to the healthcare facilities, to the community leaders. And there is not enough effort put in their operationalization and making sure that they are being followed. As an example, we have seen, for example, in DRC, one of our countries of implementation, where there's been a change in the law, where adolescent girls below 18 years old are now allowed to access services and to access contraceptives without the authorization or the presence of the legal guardian. This has been a change in law and policy that was very welcomed, but unfortunately, this change has not been communicated to different stakeholders, which means that the healthcare workers in different facilities were not aware of this change of policy and law. And they were refusing to provide the services and commodities to adolescents. Another crucial example, I think, is to make sure that the regulations and the changes in policy have an effect directly and are applied in the operating procedures, in the regulations of the healthcare facilities directly. We know through our SHARP project that a lot of health facilities are not really being supervised by the health authorities in certain countries, in certain counties or provinces. There is very few visits, supervision visits to make sure that the healthcare facility is following the regulation at the national level. So we really try to encourage local authorities to make sure that the policies are being followed and that the different regulations are part of the standard operating procedures at the healthcare facility level. Another point that I wanted to add is the need for support for opinion leaders. As I've said earlier, and I think you will all agree that sexual reproductive health is a very sensitive subject. It's very difficult to discuss it. It's sensitive, it's taboo. And this is why we make a great effort in the SHARP project to really include religious, faith, traditional leaders in all discussions. They have a huge influence on their communities. And of course, they will say things during the mass, in their mosque, etc. And if we manage to get them on board with us and to see that discussing sexual reproductive health is crucial, they see themselves, and many of the faith leaders I have met through our trips to the Great Lakes have said that they see pregnant teenagers in their mosque, in their school. They see school dropout. They see the cycle of poverty going deeper and deeper. And they do agree, for some of them, that it's time to face the reality that society has changed, and it's time to face reality. So I think it's really crucial, and our partner Faith to Action network has been crucial in this matter, to include religious leaders and faith leaders in policy discussion, in decision-making spaces, so they can be on our side and also help disseminate correct information to their constituencies.
Great.
And finally, because
I was waiting for that term, finally.
Finally, I think it's also crucial to include adolescents in the discussion. We are talking about adolescent sexual reproductive health. Most of us here, I think, are adults, although I do see some SHARP youth champions. Hello, guys. I think it's crucial that we don't do things for them, but that we do things with them. They are the ones who know what they've experienced, what are their wants, what are their needs, and they should be there when we're talking about their health. Thank you very much.
Thank you so much, Ange, for that presentation. So our next speaker is Maganga Hadija. She will introduce herself, and you have 5 minutes, Khadija. Do you have Khadija?
Hello, I hope I'm audible.
Yes, I can hear you.
Hello everyone. My name is Hadija Maganga. I'm adolescent and SRHR activist from Tanzania. And thank you so much for the opportunity to share a bit on what was being discussed. And I was very surprised not to hear the segment of adolescence, because when you're talking about SHARP, it's all about adolescence. We can't discuss things related to adolescents without having them adolescents in the call. So thank you, the entire ENASO team, for the opportunity to share a bit. First, as a young person, for us, it's not much about the numbers and the millions of monies, but for us, it's more about the services. We may not be, we may know that the budget is increasing, but for us, if the services are not friendly and if we are not really able to access the specific services when we need, then the number may be just, we may look at the numbers, but for us, it's more about the services. So my call to action will be to for government, policymakers, and other stakeholders to make sure and to prioritize the increase of domestic financing for women and adolescents' health, because it is very, very, very important to us. Yeah, thank you.
Thank you so much, Khadija. Definitely, nothing for us without us. That is what the young people are telling us. And our next speaker, Nga Murombezi, is a development practitioner and an anthropologist. She focuses on intersection of gender-based violence and HIV, particularly the challenges faced by adolescent girls and young women. Nga, you can speak to us. You have 5 minutes.
Thank you very much, Marie, and good afternoon, colleagues. I saw everybody's camera was off, but I'm going to go right ahead and switch mine on. Like I was introduced, my name is Nga Murombezi. I'm with the AIDS Healthcare Foundation. I support the Southern Africa region, so I was very happy to hear some conversations coming out of particularly areas that are within our Southern African countries. And listening to the depth and the richness of the conversation that has just happened, my first kickoff point would be all these great things are happening in silos wherever they're happening across the world. And we are talking about exactly the same thing, and we need to bridge the gap and bring all of these insights together. My counterpart is currently at the NEAPACO conference, where they're speaking to parliamentarians on issues of domestic resource mobilization. And these are some of the insights that they're sharing. Now, as AIDS Healthcare Foundation, we work very closely to respond to issues affecting adolescent girls and young women. As a global entity, we are in 47 countries of operation. We're having these services being pioneered by and tailored to respond to the needs of women and girls in all sorts of contexts. We have them happening in Ukraine. We have them happening in Asian countries. We have them happening on the African continent through our Girls Act program. And at the basis and the heart of all of this is, how do we ensure that within the context of the political will or absence thereof, the need to strengthen infrastructure so that adolescents have services that are friendly to them, the need to respond to stigma and discrimination, the need to motivate for additional and increased resources. Within all of that, how are we ensuring that at the center, the voices, the evidence, the empirical evidence of the people we're trying to serve are being heard? I speak from the South African context because I am based in South Africa. And when you look at South Africa, women are navigating realities that some people only read of in books. And these are realities that definitely affect how they're going to consider and execute their service, their seeking of health services. We have gender-based violence. We have staggeringly high levels of unemployment. You know, and just this morning, they were deliberating on how to phrase and deliver the national budget. And within that national budget is a very small component that's going to look at health. But on the other side of that conversation was the dialogue on the national health insurance. And all of these are happening at surface level. There's no integration with the communities. You know, I'm worried about the NHI because I access services as a foreign national through the private sector. But for a woman who looks like me but doesn't have the resources, they're trying to understand the NHI in, am I going to have to spend 3 additional hours when I am paid an hourly rate to access healthcare services? Now, how do we bring that reality to our decision makers? Now, when we talk on the issue around innovations, I heard innovations around utilizing additional sources of financing to bolster the domestic resource pot. And, you know, we've grappled with this. We participated in NEAPACO last year. We are there this year. And there are excellent ideas. Sin tax, there's telecommunications tax, there's aviation tax. You know, there's taxing the private sector. There's even looking at how can we ensure that we bolster and really coordinate that public-private partnership. But within all of that, where's the empirical evidence? We are speaking as practitioners. And, you know, within the development space, we have something that's called the hero mentality. You tend to develop responses that are easy for you to implement, not necessarily beneficial to the people on the ground. So the one thing I would say we have learned as AIDS Healthcare Foundation and continue to try to implement is to build the capacity of the people on the ground. So we have what we are calling the community power voices, and we are harnessing these so we can strengthen capacity, because another word I don't like to use, but we tend to lean to, is build capacity in communities. How do we know they didn't have the capacity already? They had the capacity. When we found them and mobilized them, they had capacity. So strengthening capacity. So we are strengthening the capacity of community actors to be able to advocate for themselves. And then we're trying to see how can we bring them to interface with the decision makers. I heard numbers and abbreviations and phrases and policies that if I wasn't in the space, I would have had to Google. And yet these are the very things we expect people to understand when they're trying to appreciate and utilize the services on the ground. So how do we ensure that these services are tailored right from the language that we use to be very applicable and appreciated at the ground level? Infrastructure development has come up. Now, within the context of infrastructure development, we work very closely. So I didn't mention that our MOU in the countries that we work in is usually with the ministries of health. And part of that is to support infrastructure development because we want to position patients at the center. Adolescent and youth-friendly services. In many, many, many centers, if you go into public clinics, you will likely not find an adolescent and youth-friendly center. And yet we're talking about discrimination and stigma. We're talking about wanting young people to access services. We're talking about how do we sensitize healthcare workers to remove that barrier of stigma and discrimination. One thing that comes out a lot when we interface with our young people is the attitude of healthcare workers when they seek SRHR services. Why are you looking for condoms? Now, I can't quite remember who the speaker was who spoke about access to services from the age of 15. Now, interestingly, South Africa, with the Termination of Pregnancy Act, a 12-year-old can consent to having sex and then they can consent to getting contraceptives, right? But that goes against the Criminal Procedures Act. Now, you have to be 18 to consent to having sex, but you can access contraceptives when you are 12. So how do we bridge that gap? And within that access of contraceptives, termination of pregnancy also comes in. So there's a misalignment within the legislation that we're trying to advocate for services to be made available to adolescents, looking even at the criminalization of what we would term, especially within the child protection space, as healthy sexual development. Within the Criminal Procedures Act, it is criminalized. So young people are often tending not to fully understand what their rights are within that context. So we try to bridge the gap. And I think my 5 minutes are fast coming. I think I've reached now 2 minutes. And so basically what I want to say is through our Girls Act program and our overall advocacy, not only in South Africa, on the African continent, but globally as an entity, we are within the health dialogue, the financing dialogue, and we want to build the capacity and facilitate the conversations from our decision makers side to our community members to everybody along that trajectory. And one of the things we do, just off the top of my head, is we try to respond to the need for political will by ensuring that our parliamentarians that we call friends of the organization fully understand issues around domestic resource mobilization, issues around the health side of it being particularly conversations within that space. Why do we advocate for access to SRHR services, for example? What does it look like on a financial perspective? Why do we want to speak to the ministries of health and the ministries of finance together? Because we need to see where that intersection is. But yeah, I think in summary around this would be for us to effectively mobilize resources for the benefit of women. We need to ensure that the political will is also supported by the realities. Our politicians are not hearing what it really means for a woman to have to navigate socioeconomic disparities and try to access healthcare services and try to function at their full capacity and try to make sure their mental health is aligned. There's many things that women are really battling with. And so when we're asking for this, it's for the overall benefit of the country. Maybe what we need to do is to say, when you are not investing in women and girls and the health element, when you're not ensuring that your country is adequately supported, to borrow from Lizzie's phrase, it's not just pants down that we've been caught at this particular moment, but it's going to have generational impact. We heard about contraceptives not being available already. If those young girls fall pregnant, a generation of children is going to come into this world to mothers that cannot complete their education, that then become disempowered within the economic space. And then we start to borrow again from what Amnesty International said that the face of poverty in South Africa is a teenage mother. And so how do we ensure that that doesn't become and continue to be a reality? Thank you, Lizzie.
Thank you so much, Nga. And I think that's where we come to the end of our presentations. Thank you so much to our speakers for taking the time, to just, give us your insights as far as this subject is concerned today. And thank you also to Khadija Maganga, Stephen Kibendio, Gerald Kiwele, Immaculate Omogeshwa Bazare, and Ange Murray, definitely. So Lizzie, I hand it over to you to continue.
And what I like is the sharp adolescents are in the room. If you haven't noticed, they've been dishing out comments and questions, so they know their rights and they know what they need. And I know, Dr. Kiwele, there's a question on the Q&A chat directed to you from Tanzania, from one of our adolescents. So it would be good if you do that. We are closing, and how we're doing it, it's a bit different. Of course, we're going to bring everybody, I think by now understands who Dennis Bwana is. It brings in the SRHR expertise, the advocate angle of it. But the reason why we had this caliber of speakers was for you to connect with them. We cannot finish all the discussions in an hour, 30 minutes. So please feel free to leave your contacts on the chat function, and then also request all the speakers, even the media personnel, please leave your contacts so that people can actually reach out to you later on. So I'm going to call, I'm actually taking a back step completely now. Ladies and gentlemen, this is the last time you're listening to my voice and seeing my face. I'm handing it over to our programs lead from ENAS. So Dennis Buona, are you there?
Yes, Liz, I'm here.
Ah,
I'm here.
I say nimedhani umeendea kitimoto, but okay, if you're there and it's
I'm
lunchtime, so I
here.
was worried you're having lunch. Dennis, over to you. I would request to have your video so that they remember who Dennis is. It's been, 2 months into the year already. There you
Oh,
are.
thank you so much, Liz. And what do you want me to
Now
do?
you close it up so that we can go home and I can go get lunch. Bye.
Okay. Thank you so much, Liz. As you introduced me, I'm Dennis Buana. I'm working with ANASO as an SRHR officer. And I've been following this conversation since you started. It has been really well. And I think it was supposed to be a webinar for the whole day. We break, we come back, and all that. It's really nice. And allow me also, Lizzie, to thank all the speakers. They have made very critical contributions. And to us as the program people, I think we have taken most of them on board, ready for our advocacy work that we are doing in the entire Great Lake region countries. I'm also happy I've seen Ange has introduced the SHARP project that we are implementing in the 6 countries, in the Great Lake region countries. And most of these contributions today are very significant as they add up to the great advocacy work we are doing. So as I do my closing remark, I would also wish to have a 1 minute to reflect on some of the things that I think are very necessary, especially at this critical time where the fundings are being cut and yet the work has to continue. So from my perspective, I think when we are speaking of domestic financing, it's very key. And I have at least 6 key things which I think need to be taken on board by our countries, our governments, if we are really to improve the situation and to keep the work rolling. One is to think around the innovative domestic health financing. As it stands, most of SRHR interventions have been seriously affected by the funding landscape and the ongoing cutoff of the aids. But now it's high time that our governments take a step to think and reflect on how are we mobilizing our domestic finances to cover some of these interventions that are badly affected. And some of the ways that can be used, one is through taxes. We know we normally pay tax, but it goes to some other sectors which are not equally important as the health. And we normally say, if you want to build your economy, you should start building the health of your people. So to me, health is a very first priority of all other sectors. And therefore, it is very important for our government to see the way they distribute our taxes. I can give you an example of Tanzania. If you buy 1 liter of petrol, the fuel, there is a percent within that money that you pay for 1 liter that goes for the road construction. There's a percent that goes for the provision of electricity in the rural area. There's a percent of that. That goes in all other sectors, but none out of that money goes directly to finance the health interventions. And therefore, it is very critical that as we prioritize other sectors, we also take health sector as a serious priority. But another one is balancing of national priorities. We know there is a lot of priorities, but when you put health over all other sectors, as we are approaching budgets in different African parliaments, it's necessary that we observe a budget cut in all other less important sectors and complement the ongoing health missions. So I think balancing the priorities should also be one of the approach. But the second is public-private partnership. How then are we creating an environment where private entities could come and invest on health sector? It's very important that we review the laws. How our legal framework attracting the private sectors to come and invest in health sector. There's a lot of ways to do this to ensure that private sector can build serious industries to manufacture pharmaceutical products. Family planning commodities can be manufactured in Africa, and through a very safe and quick environment where private sector can easily invest in that sector. But even we have private facilities providing health services. It's high time that we reflect on how quick the process is, reduce bureaucracies to ensure that whoever wants to build a facility, whoever wants to supply commodities, gets that access without going through a very long bureaucratic processes in our governments. But another one connected to that is the legal framework. Do we have straight legal frameworks that protects public investors? We should avoid the notion of competition between the public sector and the private sector. We bring up the legal system that supports the private sector to invest in health. Any investor will always focus on the legal framework before he injects any cent of money in the project. So the legal framework should always support the investment by the private sector. But another one is again on
and Dennis, before, because I know I totally forgot to tell people that you're an advocate. So you might take this for longer than the 1 minute we assigned you. But also when you're wrapping up, do call in our acting ED. I've just been told he's joined the call so that he can say something in less than 30 seconds. Thank you.
So that's that. Fourthly is all about taxation. How are we taxing pharmaceutical products? How are we taxing family planning commodities? What are the taxes on all these commodities that we are advocating for their availabilities? We should consider reducing tax on these essential commodities amid the challenges with funding that we have. Also give tax holidays for the investors who are investing to save the health sector. Another one is to honor the international commitments that we make and the regional commitments, especially the Abuja declarations, so that we set at least 15% on health. The last is we should embark on the integrated health system so that when you go for HIV test, you are also able to receive STIs treatment. You're also able to have family planning treatments within the same facility. So the integrated health approach is another best alternative to tackle the crisis that we are seeing by the withdrawal of USAID plus all other donors' support coming to Africa. Having said all that, on behalf of the program, thank you so much once again, team. And I think this should be a kind of a recurring webinar. At least think of organizing
we'll
another
think about adding
hours.
another International Women's Day in between before the end of the year then.
Thank you so much. In
Thank you,
advance, I wish you
Dennis.
all happy International
Great.
Women's
And
Day.
befro you close it, because you know how protocol works,
I've
Dennis,
seen ED
you're
has
an
left.
advocate.
He has left.
He has left. Okay. Roderick, are you
Unless
on
he
the
has
call?
joined back.
Roderick, are you on the call? No worries. If he's not here, please close and then we can go, Dennis. Thanks.
I saw a notification of Roderick lefting. So thank you so much. Thank you so much, comrades. I think it's necessary that, Liz, you have mentioned that there is a need of sharing contacts. We love them, and we'll really work with this amazing team in the work that we do for the SHARP project and beyond that. As Yanaso, thank you so much for sparing your time. See you next time in the next
Great.
webinars to come.
Roderick, maybe just wave because we've taken more than 16 minutes. Roderick, if you're there, you can just wave as we exit. I know you are at the NeoPACO meeting also, Roderick. There you are. That's our acting ED. Very modest. Oh, I can tell you're doing your work. Maybe say hello so that we make sure you're not AI.
Yeah, hello, hi everyone. And I've been following up some conversation and it's really great. Yeah.
Thank you very much. Man of short words. I like it. Thank you, ladies and gentlemen. Do have a good afternoon, a good day. Totally appreciate it. Have a great one. Bye.